right, hello everyone. Thank you so much for joining us tonight. I'm so excited to be here live with Dr. Edward Buchanan, and this webinar will also be recorded for future use. We are so happy to be presenting this webinar on craniosynostosis because it's one of the most common craniofacial conditions that CCA families encounter, and one of the most common questions or syndromes that we get asked about. So CCA is very excited to have Dr. Buchanan here to discuss this. I was fortunate enough to hear him give this talk several years ago, and it was one of the most comprehensive talks on the topic that I'd heard. And so when we were requested to do this again, I thought, what a perfect opportunity to have Dr. Buchanan do this talk again. So I will not take up a lot of our time, but I would like to read his introduction. We also have some prepared questions that were pre-submitted, but please feel free, for those of you watching on Facebook, to submit your questions in the chat. We do have our staff members, Kara and Annie, monitoring that, and they will be able to send us those questions over, and we'll attempt to take as many of those as we can at the end of the presentation. So be thinking about your questions, submit them in the comments, and we'll be happy to answer those. So let me introduce our speaker for the evening. We have Dr. Buchanan. Dr. Buchanan is an associate professor of surgery in the plastic surgery division of the Michael E. DeBacchi Department of Surgery at Baylor College of Medicine. He specializes in pediatric plastic surgery and craniofacial surgery. Dr. Buchanan earned his medical degree from Medical University of South Carolina. He completed his residency in plastic and reconstructive surgery at Stanford University Medical Center and his craniofacial pediatric plastics surgery fellowship training at the Seattle Children's Hospital Harborview Medical Center. He is board certified with the American Board of Plastic Surgery and a fellow of the American College of Surgeons. Dr. Edward Buchanan has written 3 children's books: The Adventures of the Prickly Pear and the Happy Hoglet, Pit Bully, The Mental Ninja Awakens, and The Tale of Finny Fox, The Mental Ninja Emerges. They are great books. I have read them. The stories in Dr. Buchanan's books encourage children of all ages to become mental ninjas and find the silver lining in all situations. So Dr. Buchanan, thank you so much for being here. I will turn it over to you now.
Thank you, Erica. I really appreciate it. This is a really tremendous opportunity. Thank you for inviting me to speak to everybody who follows your organization. And hopefully we can get some questions answered and give some information that's important. So with that being said, I think I'll just start with the presentation. Let me see if I can share my screen. Okay, once again, my name is Ed Buchanan. I'm a plastic surgeon and craniofacial surgeon who works at Baylor College of Medicine and specifically at Texas Children's Hospital here in Houston, Texas. And a large part of my practice is craniosynostosis. And so a lot of this talk will be centered towards the surgical correction of craniosynostosis. And I'm sure that's why a lot of folks have tuned in, given the fact that I'm a surgeon and that's what I do. Now, a lot of the surgeries that I talk about are the ones that are the ones that I do. And there are a few other surgeries that other folks do that I won't discuss in detail, but if you have questions, I'm happy to answer them. It's just I won't go over them too much during this talk because they're not as germane to me as these techniques that I'm going to talk about. So craniosynostosis. All right, so the overview of the presentation, we're going to talk about why we do surgery. What's the importance? Why not just leave things be in the way that they are? We're going to talk about the benefits and the limitations of surgery, the consideration for other people who need to be involved in the surgical care and not just the plastic surgery or the craniofacial surgeon, but other folks, other services that should be involved from the get-go. And then we're going to go over the brief overview of the surgery process itself, what happens, and then some patient stories. And I'm going to mostly go over non-syndromic craniosynostosis, but also I'm going to go over a few stories of syndromic craniosynostosis, which are I don't want to go too much. I want to touch on it because I don't want to only do non-syndromic, but the syndromic craniosynostosis is a very big topic, and so I want to touch on some things so that if any questions need to be answered, I can answer those. But it is a topic within itself. So let's just get started so we can get going. So what's the importance of surgical correction for craniosynostosis? Well, the functional importance is that when you have a growing skull, a baby's born and their skull is growing very rapidly. The reason their skull is growing rapidly is because their brain is growing rapidly. And if there's any restriction on the growth of the skull, which can happen with craniosynostosis, then you can get something called elevated intracranial pressure. And we think that that is not a good thing for kids to get. We know that acute elevation of intracranial pressure is very bad, because that's what happens when you get a bad car accident and you hit your head and you get swelling in the brain and things go poorly. But chronic elevation and pressure we also think is bad, because it can lead to blindness and developmental delays. And so we want to prevent that if we can. And that's why we consider correction of the craniosynostosis. And then everyone talks about the cosmetic look of a child who's born with craniosynostosis. Now, I usually don't like to use the word cosmetic, because this is not, everything is vernacular and everything is verbiage. And cosmetic to me isn't the right word. It's a reconstructive operation, because what we're trying to do is we're trying to change a head shape that is not normal into a more normal head shape. And so that is what we call reconstructive and not cosmetic. So to me, it's not a reconstructive process. But so with, if you have skull restriction in the growing brain and you have craniosynostosis, what will happen is the head shape will grow abnormally, because the brain will still want to grow despite the restrictions placed on it by the craniosynostosis. So what we do is we try to prevent that abnormal skull growth by releasing the sutures that cause that abnormal constriction. This sort of term that we follow in plastic surgery is form ever follows function. There is a reason that the skull is the shape that it is. And the reason it is because it's the way the brain is shaped. So the brain actually dictates the shape of the skull, and we want to help it achieve that normal shape however we can. So the benefits of craniosynostosis surgery are: we release fused cranial sutures and we prevent elevated intracranial pressure. The reconstructive benefits are that they correct an abnormal head shape and make them look normal. The limitations are that we usually do surgery early in life, and there can be further growth of the child after surgery. And so with that further growth, there can be some craniocerebral disproportion that can happen. And so that's something that we always watch for and that we want to be on the lookout for. And that's usually why I follow my patients all the way up until their teenage years, to make sure that we don't miss anything. And if there's any corrective surgery, we can provide that. And then with future craniocerebral disproportion, you can get future asymmetries with growth, or you can get cranial defects because things didn't heal properly from the first operation. So these are all things that we look for as kids are growing after surgery and even before surgery. So when it comes to craniosynostosis treatment, we do this in a multidisciplinary craniofacial clinic. And I recommend everyone listening that if you have a child who's born with craniosynostosis, be it non-syndromic or syndromic, that they are seen by a craniofacial team. There are many members of the team, and usually these are the folks who are on most teams. And these teams have been approved by the ACPA, which is our American Cleft Palate Association, which is one of our governing bodies in the US at least, that suggest the folks who should be on the teams based on the needs of the patients that we have. And so you want to make sure that you are seen by a team of people so that all aspects of care can be addressed and nothing is missed. So this is our coordinator at TCH. Okay, so the overview of the surgery process once we diagnose craniosynostosis. So here is the treatment timeline. So there's the initial clinic visit. Usually this happens with someone suspects that there's an abnormal head shape, or a CT was obtained early in life and it shows craniosynostosis, or the pediatrician has noticed something. I usually, with my practice, I see about 50-50. The families usually notice it right away, or the pediatrician will notice it. So it's about 50-50. Then they'll come to see us. Sometimes what we see is it's just a plagiocephaly, and then we provide helmet therapy, or we do really nothing for plagiocephaly if it's really mild. But sometimes it's craniosynostosis. And so during that initial clinic visit, we'll be able to diagnose whether it's craniosynostosis or whether it's a normal head shape or whether it's plagiocephaly. During this visit, we'll also, sometimes we get some imaging like a CT scan to see how things look. Sometimes we don't get a CT scan, just dependent on the patient. But it's during that initial clinic visit in our craniofacial clinic that we diagnose craniosynostosis. And then we decide whether we're going to do surgery or not during that time. Then the patient will go home and they'll come back for our preoperative clinic visit. That's usually about a week before surgery when we're planning surgery. And the surgery times are dependent on what kind of craniosynostosis it is. And we'll talk about that as we go through the different types of craniosynostosis. At this appointment, we also talk about the expectations of surgery, the risks and benefits, and then we do the consent, and then we move on to the actual day of surgery. And that's usually, like I said, within the same week as the preoperative visit. There's an admission to the hospital. Usually the surgery will happen and then admitted, usually not to the ICU, usually just to the regular hospital floor, 1 to 2 days in the hospital and then home after that, depending obviously on the surgery that occurs. And then you come back and see us post-operatively, and that's usually 1 to 2 weeks after surgery. And we see how things are healing and see how baby's doing. And then after that, we will see you on a yearly basis to make sure everything's going well and all milestones are being hit. So that's our treatment timeline. When it comes to the initial visit, this is a picture, sort of a bird's eye view of a normal skull, and the arrows here are pointing to the normal cranial sutures that we see in a patient, in any patient. And so all or any of these sutures can be affected by craniosynostosis. And so it's important that we know how they look when we see them. But when baby's born, all of these sutures should be open and patent because the brain is growing rapidly and it needs the room to expand. Now, these are the types of craniosynostosis that we commonly see. And the most common is the sagittal synostosis, which is the one on the top row in the middle, where the suture right down the middle of the head is fused early, and the subsequent deformity that we see is a narrow, long head. So narrow from medial to lateral from the sides, and long from sort of the forehead to the back. And so that's the most common one. The other ones that we see, the other common ones that we see are metopic and unicoronal. The most rare is the lambdoid, which is the one on the top right. And then the deformation plagiocephaly, the bottom right, is the one I mentioned earlier. This is not a synostosis that we treat. This is just what we call plagiocephaly, or that essentially translates to twisted head, which essentially means that there's been a shift, either intrauterine or after delivery when baby's sleeping, too much pressure on one side of the head versus the other, and so the bones of the head will shift. This normally corrects itself as the baby's skull grows, and we will recommend either a helmet or we'll recommend nothing depending on how severe it is, because after about 2 years, it will correct itself. So if we're going on to the specific treatments of craniosynostosis, we'll start with the most common, which is sagittal suture craniosynostosis. And like I mentioned before, the sagittal suture is the one that's right down the middle, and it is fused early, and therefore you have a very long head and a very narrow head. And so you can see the examples on the pictures there for that you can see on the right. So the surgical correction that we do, there's two. One is an endoscopic technique that we do at 2 to 3 months of age, and the other one is an open technique that we usually do about 6 to 9 months of age. I hope you can see my cursor here. But essentially the endoscopic technique, all these lines aren't incisions. The only incisions we use are an incision in the front here, and then incision in the back here. And then we remove the portion of bone that's affected, and then we make some cuts down the side of the bone to release it, so that the head can go ahead and form a more natural shape. Then after that, we put the babies in a helmet about a week after surgery, and we use that helmeting technology for about 4 to 6 months after surgery. The open technique usually happens at 6 to 9 months. We do this through, like I said, an open technique where we make this zigzag incision, or we call it a stealth incision. We normally shave the baby's head or the child's head at this point in time. And this operation is more surgery. We don't just make smaller incisions, we make a big incision. But the benefit of this is that we do not have to use a helmet after surgery. So here's an example of the endoscopic technique. There's a young man who's got a narrow head and a long head. And this is him 3 weeks post-op, where you can see that his head has sort of formed this more normal appearance. And this is just 3 weeks. Now we're going to do about 4 to 6 months of helmeting, but just at 3 weeks, you can get a really nice result. Here are the incisions here and the one in the back, and the sutures have already fallen out. He still has a little bit of what we call frontal bossing, where the forehead is slightly more protuberant because the head was growing sort of more in the anterior posterior direction. But then we see him at 6 months post-op, where he's been in a helmet, and he really has a normal looking head. You can't see the scars, they've kind of filled in. This operation takes about 45 minutes to an hour in the operating room. We do this with our neurosurgery colleagues. Babies stay in the hospital for 1 night and go home the next day. We usually see about a 50-50 chance of needing a blood transfusion for this operation. It's not so much that we lose a lot of blood, it's just that babies at, say, 2-3 months of age don't really have a lot of blood to lose. And so we know kids get in trouble when you have the surgery if they lose too much blood. And so we want to make sure we don't get in any trouble. And so we're always ready and very conservative to transfuse if we think things are too low. And so this is an example of a endoscopic technique. And so you can see the pre and the post-op shape. And like I said, this is about 6 months after surgery. So a correction with an hour-long operation with 4 to 6 months of helmeting. And then this is an example of an open technique, obviously a longer incision. This is 6 to 9 months of age, but you can see this young man in the pre-op photo, he's got a very long and narrow head. And then right away after surgery, he's got a wide and a more normal shaped head. And so the benefit of this operation is the surgery is done at the operation time. And so a lot of families don't want to deal with a helmet, and so they don't have to. But this normally does require blood transfusion because it is a bigger operation where we're reconstructing the majority of the skull. But this is just one surgery and done, and you don't have to go back and do anything further. So here's an open technique at 3 months. You can't really see the incision. It gets hidden very well within the scalp and the hair as long as it grows. If kids wear their hair short, then yeah, you will see the scar. But most families don't have the children wear their hair short. So a little review on that. Endoscopic technique at 2 to 3 months of age is when we do it. Helmeting for 3 to 6 months, 1 hour surgery, 1 day in the hospital. And then open technique, 6 to 9 months. No helmet needed, usually transfusion required. It's about a 2-hour surgery and about 2 days in the hospital. So that's sagittal suture craniosynostosis, the most common non-syndromic craniosynostosis that we see. Metopic is most likely the next most common. And this is where the metopic suture right in the middle of the forehead fuses too early. And so what happens is you get this narrow forehead. And so it's pointy, and you can get what we call hypertelorism, where the eyes are closer together. So the treatment for this is the same as sagittal. You can do either endoscopic or you can do open. Endoscopic at 2 to 3 months, just like sagittal, or open at 9 to 12 months. A little later than sagittal. We usually wait a little bit later. This child happens to have a hemangioma on the top of his scalp, but that's not related to craniosynostosis. And so if we're doing endoscopic, it's a incision just behind the hairline. These lines here are not incisions. They are just marks that guide us during the operation. So just one incision behind the hairline, we shave a little bit of hair. This child, we shaved all the hair. There is the option not to shave all the hair. We just kind of shave a little bit of hair around the incision. So for girls or for little girls, we usually don't shave all the hair. Families don't like that very much. So, but this child, we did shave all the hair. And so this is another example of a young baby not very happy with us, who is going to have an endoscopic technique at 2 to 3 months. Here's the incision after surgery. This family opted to have the whole head shaved just because we were shaving a little bit in the front. This is 1 week post-op. You already see a correction, but this child will be in a helmet for the next usually 4 to 6 months as well, just like or a little bit longer than the sagittal, just because the correction of the forehead's harder to correct with a helmet than the sagittal suture synostosis to correct. And so here he is 6 months post-op. We usually discontinue, like I said, discontinue the helmet at about 4 to 6 months after the operation. And so you can see his forehead has taken a more rounded appearance in the worm's eye view. And he's filled in the defect that we created. And you really can't see much of the incision because it's in the hairline. So here he is pre-op, and here he is 6 months post-op. Very cute little guy. And then this is a metopic synostosis that we treated open at 9 to 12 months. So with him, we did shave all his hair. And we, like I said, we do it 9 to 12 months. This is the incision that we use. One thing to note is that we normally give the children a little bit bigger of a forehead. I usually tell the families it's almost like a 2-year-old's forehead because I want them to grow into it. If you look at the growth of a skull or anybody's head, is rapid growth, say in the first 0 to 2 years of life. And then after 2 years, you kind of have about 10 to 15% more growth. So I really want to give them a nice, strong 2-year-old forehead so that as he gets into in year 2 and further into year 1, he really fills into that forehead. If we have it match him at the age of 1, then sometimes we see an overcorrection as he gets, an undercorrection as he gets older. And so this is him 1 month after surgery. And then here he is 1 year post-op. I think this is 2 years post-op. Yeah, this is him 2 years post-op. Very cute little guy. But there's the correction. So just to review on the metopic, two techniques that we use: endoscopic and open. Endoscopic 2 to 3 months of age, and open 9 to 12 months of age. And then you can see helmet versus no helmet, transfusion for the open technique, 50-50 with the transfusion for the endoscopic, a longer operation for the open versus the endoscopic, and longer hospital stay versus open versus endoscopic, just like the sagittal. Moving on to the next most common, unicoronal craniosynostosis. This is where one of the coronal sutures is fused. And essentially what this looks like, the coronal suture is the suture that's right above the eye. So this little young lady has a unicoronal, which is this suture here. You can see on the opposite side that is open, but on the right side it's affected. And so what happens is you get a flattening of the forehead on the one side, and then you get an asymmetry to the eyes, where the eye on the right side, the affected side, is taller and narrower than the eye on the unaffected side. And so the most common way I do this technique is open technique at 10 to 12 months. And the reason I do that is there are some centers who will do an endoscopic technique, and actually we have done them here. I'm still waiting to see the results in regards to the eye. The forehead gets corrected fine, but the eye, to me, I don't know if it gets the best result. And I know when I do the open technique, I can get the eye symmetric with the opposite eye. And so here's a little girl who we did, and this is actually, I don't have her pre-op. Oh, the pre-op photos I showed you already. Here she is 2 weeks after surgery. And so she's swollen. This is kind of some of the swelling you can expect after surgery. She's happy. Here are her sutures inside. So we did a limited hair shave on her, where we don't take too much hair, just a little bit around. And so here she is 2 weeks out. And here's her forehead, has a nice shape to it. She's a little more swollen around her affected eye than she is around the normal side eye. And then here she is about a 1 year post-op. And here's her forehead and her eye. And here she is at about 2 years post-op. So we were able to correct the eye width and height, and we were able to give a nice round forehead, which is symmetric. So, so I tend to do these. I tend to do these children open, but I have done them. Endoscopic. It's just my results. I don't have the longest series with them endoscopic. There are some centers that will do them endoscopic routinely and more often than not, whereas here we tend to do these open. Bicoronal craniosynostosis, when actually both of the sutures up above the eyes are fused early, what you see is you get a very tall orbit, and it makes the eyes look very wide because the orbit is very tall, and then the forehead is very flat. So the way I do these is open at 10 to 12 months because I know I can get a nice correction. And like I said before, I think there's some folks who do this endoscopic as well. But here she is pre-op, cute little lady. Here she is 2 weeks post-op. just like we saw the boy with a metopic craniosynostosis, a very, very strong forehead. Like I said, I tend to give the kids about a 2-year-old forehead because I want to overcorrect so they can grow into it. Here's the incision. The family opted to have all of her hair shaved, so it would grow in evenly. Being very stoic there, and then she started crying on us, but she's allowed to do that. And here she is 1 year post-op. And here she is 2 years post-op. She wasn't quite happy to be there. She was slightly blinking there. Yeah. So here she is 2 years post-op. Okay, so unicoronal and bicoronal. Both of these I do at 9 to 12 months with no helmet. There is a transfusion required. It's a 4 to 5 hour surgery and 3 to 4 days in the hospital. The lambdoid synostosis is the most rare. And normally we do these endoscopically at 2 to 3 months or open at 6 months. So this one we do both ways. If we do it endoscopically, we do a helmet. These are harder to diagnose because they're often confused with deformational plagiocephaly, which is the kind of plagiocephaly where you use a helmet to correct. So sometimes they get confused, and so we don't see them till later. But these are both done endoscopically and open. You can see it's flatter on the one side than the other. Here's open technique done 2 weeks post-op with a nice round back of the head. So like I mentioned before, lambdoid, endoscopic technique or open technique, similar to the metopic, similar to the sagittal, different from the unicoronal and the bicoronal. Okay, so in summary, for the non-syndromic craniosynostosis, there are different surgical times for different techniques, but we, for the majority of them, will have endoscopic and an open technique. And if you do an endoscopic technique, then you will expect helmet therapy after surgery. If you do it open, then no helmets, but it is a little bit longer of a recovery. So that is the long and short of non-syndromic craniosynostosis. I want to touch briefly on syndromic craniosynostosis. Let me see the time here. So yeah, it's been about 30 minutes. So maybe I can give about 10 minutes on syndromic craniosynostosis, even though it's a huge topic and definitely requires more, but I just want to touch on it so that we can go over some common things. So the most common syndromes that we see that with syndromic craniosynostosis are 𝐴PERT, Crouzon, Pfeiffer, Monkey, and Sather-Chotzen. And these are the genes that are commonly affected with these syndromes. So they usually present with either a bicoronal craniosynostosis or multi-suture craniosynostosis, which essentially means when we talked about non-syndromic craniosynostosis, the previous topic, that was just one suture. These children usually present with many sutures. And so the complexity of their care is elevated greatly. And so we have to add not just one operation like we did with non-syndromic, but now we're talking about multiple operations to correct the deformities that we see. These children also have other associated anomalies depending on the syndrome that they have that need to be addressed and treated by medical professionals. So about 75% of them will also have intracranial anomalies, so inside the brain. So definitely your neurosurgeon at your center needs to be involved with these children very early. It's about 1 in 25,000 is the prevalence, and then it's a genetic mutation, and these are the genes that we normally see. So the pathophysiology that we see with craniosynostosis, so essentially what that means is the issues that develop as the children get bigger, it's a complex form of craniosynostosis. So not just one suture fused, multiple suture fuses are fused, and therefore what we see is the incidence of elevated intracranial pressure goes up dramatically. And so we really have to be aggressive with what how we treat and how much room we're able to give the brain. Then there's also skull base involvement, where the sutures on the skull base can be fused, and therefore the base of the skull is involved, and it leads to other kinds of problems like facial differences and changes around the ear canals and changes around the foramen magnum where the brain lives and the brainstem are coming through. And so these are all things that we need to be aware of and we need to assess for so that we don't miss something. So these are the things that can result because of this complex craniosynostosis. So the goals of surgery when it comes to syndromic craniosynostosis are correction of the craniocephalic disproportion. So essentially what that means is the brain lives inside the skull. And so the brain is going to grow and it wants to grow. So we have to make sure that we give it enough room to grow and don't have any pressure on it to cause any problems. So we need to correct the disproportion that we see when it comes to multi-suture craniosynostosis. And therefore we prevent elevated intracranial pressure. We also want to protect the eyes because the skull base is affected. The orbits are affected. The orbits don't grow well, and therefore they're not there to protect the eyes, which are still growing. And so they can be very bulgy and push out against the eyelids, and sometimes they can get exposed. And so we have to be very cognizant of that, and we have to protect the eyes so that they don't get damaged or ulcerated. And the other thing is because the skull base affected, the airway gets affected, specifically the nasal airway, because the midface doesn't grow appropriately. And so we have to be aware of that. Sometimes this will lead to a tracheostomy for airway protection. Sometimes this will lead to early intervention, early facial surgery to help with breathing. So all these need to be addressed. The key to all these goals is that we want to achieve all these with as few operations as possible. So we have to be very strategic about how we address any patient with syndromic craniosynostosis. And all patients are slightly different. Even if they fall within the same syndromic category, they all have slight nuances that are specific for them. And so they need to be addressed very personally. And so that's what a team will do for you, is a team will give you that personal care so that your child's issues are addressed appropriately in a timely fashion with not a lot of operations, but operations that work and operations that are effective. So the surgical summary for patients with craniosynostosis is it's usually a staged surgery, stage surgeries, and they're usually patient specific. So this is just one example of how I treat a lot of patients with syndromic craniosynostosis. Now, please be aware that this is not for every single child, and I take patients with syndromic craniosynostosis very individually because they all have individual needs. And so, like I mentioned before, this is a topic that we can go on forever. But the first thing I normally do with patients with craniosynostosis, with syndromic craniosynostosis, is I want to increase the size of their cranial vault, because I want to give the brain as much room as possible to grow without any hindrances. And so the first thing I normally do is what we call posterior cranial vault distraction at about 6 to 8 months of life. And essentially what this does is it moves the back of the head backward, and it gives the brain a tremendous amount of room so that we don't develop intracranial pressure early. The second thing I do is normally proceed with what we call a frontal orbital advancement about 12 to 18 months, so that I can provide for more room, but also provide for orbital protection, because a lot of kids who have syndromic craniosynostosis will have exposed orbits. And they'll have exposed, their eyes will be proptotic, and so we want to protect that. The third operation we do, if everything goes well in the first and second operation, is we wait usually till about 8 to 10 years of age. If the child can wait, like I mentioned before, this is sort of a cookie cutter approach, and every child is different. So I want to make sure that you know that. But part of this talk is that I'm going to go over each one of these surgeries, because lots of kids with syndromic craniosynostosis will need one, if not multiple, of these operations. And so I want to give you just some pictures so that you have an idea of what that will look like. So the third operation is something with the midface, either a Lefort 3, which just moves the midface forward, or a monoblock, which moves the midface and which moves the forehead forward. And then the fourth operation is usually when patients are hormonally adult, and that's orthognathic surgery in order to get the teeth in good alignment. And like I mentioned before, this is very patient specific. Okay, so I'm going to go over a few patients here. These are syndromic patients, of course. This is a Craniosynostosis child that we treated, and here he is, 3 months old, and this is his CT scan. And he has developing multi-suture craniosynostosis. What we know about Craniosynostosis syndrome, and like I said, this is just one example, is that even if they present with just 1 or 2 sutures fused at, say, 3 months, all of their sutures will eventually go on to fuse. So we know that they're going to develop elevated intracranial pressure. So we treat them as if they need more room from the get-go. So essentially what we'll do, and this child was born what looks like a sagittal and bilambdoid, bilambdoid. But with time, at 5 months, you can see that he starts to fuse. 5 months, he starts to fuse all the sutures. You can see his coronal sutures fused, and his sagittal suture in the back is starting to fuse. So Cruzons typically will develop what we call a pansynostosis as they get older. When I say older, I mean within the first year of life. So because they're going on to fuse, we do something called a posterior craniovault distraction. This is an X-ray of that, and these are little distractors. Essentially, we make a cut in the bone, and then we put these little distractors on, which are essentially little ratcheting mechanisms, and we turn them, and they essentially move the head backwards, and they give the child's brain more room. So here he is after we've done the distraction. You measure this out, it's about 2 centimeters, and so we're able to really increase the cranial volume. And then here he is with the distractors coming through the skin. Sometimes they come through the skin, sometimes they don't. Kids usually aren't affected by them. Here's the incision that we use. And here he is, I think, right before we went to go take the distractors out. So we do this at 6 to 8 months of age. And then at about 12 months of age, we go back and we do what we call a frontal orbital advancement. So here he is after that actual surgery, the frontal orbital advancement at 12 to 18 months. Now he is still proptotic, but he's able to protect his eyes now. But he's proptotic because his midface is severely retruded. And because of that, if his airway is okay at this age, we'll support him and we'll wait until he's about, and here he is at 2 years of age. But normally with this child, he's still in treatment and he's not quite 8 or 10 years, but he's doing fine. But a child like this would most likely get an operation like a Lefort 3 or a monoblock when he's 8 to 10 years of age in order to move the midface forward and or the forehead if he needs it. Like this young lady. So this young lady is 8 years of age. She has Cruzon, and she needs a Lefort 3. And so we went ahead and did that for her. As you can see, her forehead is back. Even though her forehead is back, she didn't need any more intracranial volume. So we actually put a forehead implant when we did the Lefort 3. Lefort 3 operation, what is that? Well, essentially what that is where you're making a cut just below the orbits through the nasal frontal region, and essentially doing a disjunction. And we're moving this forward, and you can see her x-rays here after we moved her forward and we plated her. So this young lady, we moved forward about 8 or 9 millimeters, and we plated her in that place. And then we calculate that distance based on our computer modeling that we do before surgery so that we get the movements exactly how we want them. And here are our x-rays afterwards. And here are our pictures afterwards. So this is about 1 year after surgery. And here's our pre and post-op picture. So this young lady got that mid-face advancement Lefort 3 at 8 to 10 years. So that was a Lefort 3. Now, if a child also needs to have the forehead done at that age, 8 to 10 years of age, because they need more intracranial volume, or their forehead is not as forward as it could be, and they need better ocular protection, then we'll do something called a monoblock. And so what is a monoblock? So this young lady is going to get a monoblock at, I think she's 8 years of age in this picture. So a monoblock is essentially like a Lefort 3 where you're moving the midface forward, but you're also moving the forehead forward at the same time. Now, this picture here from one of our organizations, the AO, has some plates and screws here. Now, I don't do this operation with plates and screws where essentially we put plates there. I actually do this operation with distraction, where we put a headgear on, and I'll show you pictures of that. But essentially, this is a picture of a real patient, of this young lady after surgery, where she had the monoblock and the monoblock cuts done. She has some wires here in order to help pull things forward with our frame. And so here she is after surgery. She's 3 weeks post-op with the frame on that we're using to pull her face forward. And you see that the frame goes on the skull. So it attaches to the skull with these screws here. And then it goes there's a bar that goes right down the middle. And then the crossbars here attached to screws that are placed on the brow and right next to the piriform aperture, which is right next to the nose, the nasal aperture in the face. And then we pull from these areas. And after a certain period of time, usually about 2 weeks of pulling, we stop, we let things consolidate, and then we take everything off. But here she is about 3 weeks afterwards. And here she is about 18 months post-op. And you can see she's got a significant correction. Her eyes are in a better position. Her nose looks better. She's a better nasofrontal area. Her teeth are coming together better. She's able to breathe better. And her forehead has a better projection. And so all these things it's a very powerful surgery. It's a very good surgery for these types of issues because it corrects a lot of problems at one time. So here she is. And so here she is pre-op versus post-op. So like I mentioned before, when you treat patients who have syndromic craniosynostosis, it's staged, and it needs to be staged according to the patient's needs. And so that's very important to have that discussion with your neurosurgeon, your craniofacial surgeon, and your whole team, so that you don't have to repeat operations and do unnecessary operations. But this is, like I said, this is a cookie cutter way of thinking about this, but not every patient will go down the same trajectory. This was just something that I wanted to bring up for discussion purposes, but also to show you the different techniques that we commonly use for patients with syndromic craniosynostosis. So in summary, I think I've gone for about, that's it, 45 minutes. Craniosynostosis can be a very complex problem, so it requires a multidisciplinary team. If it's treated by a multidisciplinary team, it becomes not as much of a complex problem. So you should seek specialists who really treat this a lot and see patients with these conditions all the time. There's resources available to understand the process easier. You can always email me. Of course, the CCA is a great organization, so you need to reach out to them. That's our craniofacial coordinator, Stephanie Yaus. This is where I work at Texas Medical Center in Houston. But thank you for your attention. I'm sorry I droned on and on, but hopefully you got some information out of it. And this is some pictures of our annual craniosynostosis reunion that we have every year with all of our kids coming back to visit the team. So thank you very much.
Awesome. Awesome. Thank you so much. That was very comprehensive. And we do have some questions. So
Okay.
I definitely appreciate that overview. I think for so many people just figuring out what's going on, they absolutely got an excellent overview and probably prompted a lot of questions. So I'll take some of our submitted questions that were live first, and then we'll go back to the pre-submitted questions. But if people are with us now, I want to go ahead and get their questions answered. So one is about diagnosis. So if you notice some frontal bossing or protrusion, and specifically in a baby girl, does that indicate craniosynostosis, or can it?
It could, because we do see frontal bossing in patients, in kids who have craniosynostosis, but it's not, it's not 100%. And so I think that's one of the important reasons that you need to go seek out the folks in your community who treat craniosynostosis, is that some kids, kids all have different head shapes when they're born for one reason or another. What you want to figure out is whether the head shape is a result of something that doesn't allow the head to grow normally. And so that is best done by folks who do this all the time. If there is a bossing forehead and there's no craniosynostosis, the chances of it getting better are probably high, because whatever it led to, whatever caused it when baby was young, she can probably grow out of it, because the brain is really, remember, the brain is what dictates the growth of the head, and the brain is going to be growing dramatically, and so the skull will follow the shape of the brain.
Makes sense. Makes sense. Thank you. Another one says, another one of our audience members says, my son is due September 27th. Multiple scans have suggested that he likely has bicoronal craniosynostosis. Question: if he in fact does have this at birth, how early can the surgery be completed? And what is the potential of needing a second surgery later on?
Okay, that's a great question. So what needs to be determined straight away after delivery is whether the bicoronal is syndromic versus non-syndromic. And so that will dictate the rest of the care. But if it's non-syndromic, then usually it's a one operation, and then that's it. Okay, they can be treated with one operation and then no more operations with growth. If it's a syndromic craniosynostosis, it's slightly different, and then we would need to figure out which syndrome it is, and then go down that pathway to figure out what the appropriate care would be. And depending on the syndrome, we can get kind of specific or not so specific, but the syndromic bit kind of changes things. But usually, like I mentioned before in the talk, if it's syndromic, it's usually staged, so multiple operations in order to help. There are some syndromes that don't need multiple operations. One I'm thinking about specifically is monkey syndrome. Usually that doesn't need multiple operations. But with that being said, it's and so the other question was how early you can have surgery. So bicoronal, like I said, here I usually treat bicoronal open. So I normally do it at 10 to 12 months of age. I know there are some centers who will do it endoscopically, and so they would do that earlier, say 2 to 3 months of age, and then put the baby in a helmet at that time.
Perfect, thank you. That leads me to another question. What is considered generally safe for anesthesia? What age is the earliest that you typically put babies under general?
Yeah, you put me on the spot here. So this is a harder question to answer because in the last few years, the FDA came out with some recommendations in regards to children under the age of 3 needing what we call elective surgeries, and saying that they shouldn't necessarily have elective surgeries because we don't know the long-term risk of having general anesthesia under the age of 3. So lots of things that I do in plastic surgery, some may consider elective. Now, I don't consider craniosynostosis an elective operation because the downsides of not operating are, for a lot of them we don't know, but a lot of them we do know, and they can be quite devastating. So, so with that being said, we believe that doing an operation far outweighs the risks of not doing an operation, and we believe the risks of anesthesia are not greater than the risk of not having a surgery. And so, like anything in medicine, you always have to weigh the risk-benefit ratio and figure out what the better side of that is. Now, in regards to the anesthesia bit and having surgery below the age of 3, I'd have to have my wife is a pediatric anesthesiologist, and there is a very long, complicated answer there that I'm sure she could answer better. But I don't think it applies for kids with craniosynostosis because it's not exactly elective.
Makes sense. Thank you. Thank you so much. Another question. Do you notice a correlation between sagittal suture fusion and macrocephaly? Specifically, do you see a decreased head circumference or a leveling off after endoscopic? After
an endoscopic correction?
Yes.
So I'm going to leave the macrocephaly part alone. Just looking at endoscopic technique with sagittal suture craniosynostosis, normally those children will continue to grow on a normal curve. And so they won't become macrocephalic. They will not become macrocephalic. They'll actually become normocephalic, and they'll actually continue to grow because their other sutures are also still open. So those are still growing. It's not exactly like when you take the suture fused out, the sagittal suture out, it will form a new suture. That doesn't necessarily happen. But the other sutures are still present, and usually they can still continue to grow. So the head still continues to grow, but now it grows in a more normal orientation that you created when you did the endoscopic repair. I haven't seen any association between endoscopic suture, sagittal suturectomy and helmeting and macrocephaly, or open sagittal suture correction and macrocephaly. I haven't seen that.
Thank you. Thank you. Another question, would Chiari malformations, are they linked to syndromic craniosynostosis? And is it something that is commonly seen with non-syndromic craniosynostosis?
Yeah, so I answered the last question first. No, it's not commonly seen with non-syndromic craniosynostosis because we believe that the craniocerebral disproportion, the size of the skull is not as affected with a non-syndromic, and that's why we don't see very high incidences of elevated intracranial pressure in non-syndromic patients. Now, syndromic patients, because they have more than one suture fused, there's more constriction, and so the cranial vault where the brain lives is smaller, and so we do see higher incidence of Chiari. Chiari essentially is where the posterior part of the brain is getting pushed down into what we call the foramen magnum, which is the hole where the spinal cord comes through. So some of the brain gets pushed down into that area, and it can cause neurologic symptoms which need to be treated. And so, yeah, the answer is yes, we do see those. And one of the reasons we also think it's there, not only for the multiple sutures, but also because the skull base is involved. And so we don't think it's as big. And so the brain just doesn't have as much room. And so it goes where it can, and down through the foramen magnum is where it goes sometimes.
Awesome. Thank you for answering that. I'm going to combine two questions here because one person asks, is there a non-surgical treatment option for craniosynostosis? And the other question was, do you ever use distraction osteogenesis for non-syndromic craniosynostosis?
It's a good question. For non-syndromic, I don't. And the reason I don't is because the techniques that we have are very effective, and they get the correction without needing to do distraction. Distraction is very good when you have a complex problem that you don't have a good solution for. And for instance, syndromic craniosynostosis, we usually need a lot of volume because there's so much constriction in the skull growth. And distraction allows us to do that, because what distraction allows you to do is not only increase the bones, increase the size of the intracranial volume, but also it allows you to stretch the skin. So if we were to try to do some of the maneuvers that we are trying to achieve with distraction with just normal techniques, really the skin would limit us. We would never be able to close the skin because it's just too big of a movement. So distraction is really good for kids who have syndromes that we really need a lot of volume. But normally with non-syndromic, I don't need to do that. I don't think of any kid I've ever had to do a distraction for non-syndromic.
Awesome. And is there currently a non-surgical treatment for craniosynostosis?
Not that I'm aware of.
Okay. All right, I have a few more. We have so many questions. This is wonderful. Thank you everyone for tuning in and submitting your questions. There is a common question we get. What are the long-term expectations? Do you see any learning difficulties, other problems that develop for children with non-syndromic craniosynostosis?
So for non-syndromic, no, we don't normally have any developmental delays, not like a common thing that we're expecting, right? And so all of our kids are seen by a neuropsychology team, and they're evaluated every year. And so essentially we see how their progress is, but we don't normally see like an expected motor delay, fine motor skills, cognitive delays. We don't see these things. And so the answer would be no. If children are treated and there's no intracranial pressure, then they should have a totally normal development.
Wonderful. That is good news. Another question: if you get diagnosed a little bit later, is the endoscopic option completely out for you? Do you have to go open past a certain age, and why?
Yeah. So if you come into so we normally say endoscopic, we try to do about 2 to 3 months of age. So it's good to be diagnosed early, say 1 month or 2 months, so we can get you into the operating room. We're able to really expedite you so that we can get it done, because I know a lot of families want to go with smaller incisions, smaller surgeries, less hospital time. But if you come in later, like say 4 or 5 or 6 months, then we haven't seen the endoscopic technique to be as effective. And so what that means is that we don't quite get the correction that we're looking for. And so we could go and do an operation, but if we don't get the results that we want, then we may have to do another operation. And so that's 2 operations. And so we normally dissuade families from trying to, well, we actually don't even offer it. It's because we know that it's just going to, it's not going to lead to anybody's happiness. And so yes, so there is a point where you can't get endoscopic anymore. And the other reason for that is, the reason it's effective is because babies, when they're very small, their heads are very soft, their bones are very soft, and they're very malleable, and they're also growing very rapidly. And so you want to capture that growth potential early on. And if you release the affected suture and then let them grow, then they'll just kind of grow normal. But if they've already grown and their skull is getting thicker, it's really hard to manipulate the skull with a helmet.
That makes sense. Thank you for explaining that. All right, I have one more specific question and then 2 general ones, and that'll probably bring us to our time. Our specific question is, my daughter has a multi-suture, non-syndromic, right coronal and sagittal craniosynostosis. She had endo at 4 weeks and is 5 months now. What is the likelihood of a second surgery due to her harlequin eye?
Oh, her harlequin eye. Yeah, that's a good question. So the person who wrote the question is kind of hovering around the reason why I normally do unicoronals open. I find it very, very difficult to correct the eye difference with an endoscopic technique, because when you do the endoscopic technique, you're just releasing the suture and then putting the baby into a helmet. So you're not really doing anything with the eye itself. However, the proponents of endoscopic techniques suggest that with the normal growth of the brain on the side of the affected suture, if it grows normally and pushes the forehead forward, then it could correct the eye deformity. And that may be the case. And so if she's only 5 months now, and she's already had surgery, I would really give it time to let her grow, because realize she's growing from now and now until 2, like very rapidly and like exponential growth. And so that frontal part of her head is going to be really growing fast. And so it very well could correct it. But I can't like guarantee or 100% say that, yes, it will correct it. It'll be interesting to see. I know there are proponents of it who say that it will correct it. In my hands, I just haven't seen, I haven't been satisfied, but it doesn't mean that I can't become satisfied with if I see more examples of it.
Sure, absolutely. All right, I will wrap up with a couple of general questions. This one says, does anyone know what causes craniosynostosis?
Well, we know what causes syndromic craniosynostosis, or we think we know because of the gene issues. So the answer to that is yes. So non-syndromic craniosynostosis, what everyone always says is it's multifactorial. So what essentially that means is we don't really know, but we think it's a bunch of factors that are contributing. So there's probably a genetic component. Is there anything environmental? I've never heard of anything specifically. But with that being said, I would say multifactorial and probably probably a strong genetic component that we just don't know about.
More to learn, always more
Yes.
to learn.
Right.
All right, and we'll finish on this question. So if a parent out there is listening and they suspect craniosynostosis, what should they do? Who should they reach out to? What is their first step?
Well, depending on where they live, I would reach out to the children's hospital local to them to see if they have a craniofacial team. And if they do have a craniofacial team, then I would make an appointment with them. And I would go and talk to the providers there. And then at that point, it becomes, do they feel comfortable with the team? Are they comfortable with the information they got? Are they comfortable with the treatment plan? And if they're not, just like any kind of medical condition, seek a second opinion. Obviously they have a resource that you provide that is very valuable. And so if they're not happy with the first opinion or the second opinion, they can always probably reach out to you, or they can always email me if they want to. I'm happy to answer any questions, but they can reach out to people who are in the space and know craniofacial syndromes to get better answers. But I think the key is information. The more informed that any patient or family is, the better they're going to be able to pick the treatments that are effective and that get their children to the place they want them to be. And so information, do your research and seek out the professionals who do this for a living all the time.
Awesome. Thank you. And yes, I do want to remind everyone that CCA is able to help financially if you're traveling for a second opinion, or if you are going in for a surgery or an overnight stay. So just reach out to us. We're happy to help with that. I want to see if you have any closing thoughts, Dr. Buchanan, but otherwise we're so grateful for the time you've taken tonight. So just anything you'd like to add there at the end for our parents and patients watching?
Just that I'm very happy and honored that you allowed me to speak to you today. I hope my presentation was clear. Hope I didn't talk too fast or run over my words, but thank you for tuning in, and I hope you got something out of it, and feel free to reach out to me if you have any further questions. And thank you for hosting me. I really appreciate it. It's really nice of you to have me here.
Absolutely. The gratitude is all ours. We really appreciate that. And we appreciate everyone watching. We will make this recording available. So if you want to share it with other families, you can absolutely do that. But everyone watching tonight, thank you so much. Thank you, Dr. Buchanan and Texas Children's Hospital. We really enjoy our partnership together. So have a good night, everyone. Thank you so much.
Great. Take care.